Well, we'll start slowly because I think people will still be coming in, and then we'll see how full the room gets, but we'll want to end on time, I'm sure. I wanted to thank all the speakers for coming today, and there's a couple of extra people here too, and I wanted to introduce them right off the bat. We have Dr. George Hackman here from the University of Waterloo. And Veronique Boscart, who is the Schlegel Research Chair in Nursing, has joined him also and will be presenting with him. Dr. Alexandra Papian-Ioannou, I completely, from McMaster University, and she'll be presenting on vitamin D and the osteoporosis study. And then we have Lori Brown from NP Stat and Dr. Stuart Egier from Trillium Healthcare, who will be presenting on the use of order sets to enhance long-term care. And if we do end on time, we'll have our question period at the very end, and we'll be able to address any items, questions, comments that you might have at that time. So I would like to start with introducing Dr. George Hackman. He is currently the Schlegel Research Chair in Geriatric Medicine, Associate Professor in the Department of Health Studies and Gerontology at the University of Waterloo, and Assistant Clinical Professor of Medicine, McMaster University. He specialized in internal medicine, U of T 1999, and geriatric medicine at McMaster in 2000. Holds a Master's of Science in Health Research Methodology and an M.Math, Computer Science from University of Waterloo, and Engineering Physics from Laval University. Dr. Heckman's primary research interests and projects include primary panel, Canadian Cardiovascular Society consensus guidelines on heart failure management in the frail elderly and long-term care residents, with current funding from the HSFO and prior funding from the CIHR. Dr. Heckman is also the lead geriatrician for the Waterloo Wellington LHIN. And joining him will be Veronique Boscart, who is the Schlegel Research Chair for Nursing. So please, I welcome you.
Thank you very much for having me. And I just want to point out that Alex helped me become a geriatrician. She was at McMaster University, so I owe her a debt of gratitude. I'm also a hockey trainer, but that didn't come out in my biography, but my wife said, that's it, no more degrees. Hockey trainer is your last one. So we're going to talk about heart failure specifically in Ontario long-term care homes, and specifically barriers to heart failure management and some of my disclosures. This is something that we've been working on for about 10 or 12 years now, and I've been interested in heart failure for that long because when I was a resident, I would go to nursing homes and I'd be asked to see residents who were cognitively impaired or who were functionally impaired, or there was some sort of geriatric syndrome going on, and invariably heart disease was playing a major role in how they were. And we were wondering what was going on that the heart disease wasn't being picked up on, let alone dealt with. And obviously there's many issues, as you'll see. But the interesting thing was when we dealt with their heart disease, cognition got better and function got better. And so this is an important concept in terms of managing the health of these folks on a chronic basis. So just so everyone is on the same foot to start with, what's heart failure? So heart failure is a syndrome. So essentially, someone's heart has been damaged through some sort of mechanism, usually a heart attack, or long-standing high blood pressure, or diabetes, or alcohol, or something has damaged the heart. And as a result, the heart isn't pumping efficiently anymore, or it can only achieve good circulation to the vital organs by having the body increase the amount of fluid that it's got to move around. So essentially, you have symptoms and signs of poor cardiac output that are the fatigue and the feeling cold and the low blood pressure, and or the symptoms of volume overload when they have to have all that extra fluid to, maintain blood flow to vital organs. And that's why you get the congestive portion of this, where they have fluid in their lungs, fluid in their legs, fluid in their back, and essentially they feel like they're drowning all the time. So that's heart failure. And it's an issue in long-term care because Some studies have shown a prevalence as high as 45%, but the most recent systematic review basically suggests that about 1 resident in 5 in long-term care will have had heart failure at some point. And it's a chronic state. You don't get over heart failure by and large. And it's obviously a very lethal disorder. So in long-term care, mortality at 1 year is over 40%. And if you happen to be a long-term care resident who gets hospitalized for heart failure, your mortality is about 90% at a year. It's an end-stage kind of event. And from a health system's perspective, not only is it a miserable thing to live with as a person, but it's responsible for many, 15% of long-term care transfers to emergency departments and acute care. And all of these seniors are sent there by ambulance, and they stay in the emergency for a certain length of time. If they get admitted, they stay in hospital for about a week. And even getting back to long-term care after a hospital stay, a fair number of them actually have to wait for the bed to become available again. So it's quite a burden, not only on the person, but on the system. So I sit on the primary panel for the heart failure guidelines of the Canadian Cardiovascular Society, the CCS. And as a primary panel, we're charged to review all the literature related to heart failure, and specifically heart failure in seniors and in long-term care. And by and large, all the evidence that is out there, a lot of it is observational, but there are some small clinical trials, suggest that the general guidelines for all heart failure patients do apply by and large to long-term care residents. So there are also potential benefits to treating heart failure optimally in long-term care residents, which may improve cognition, improve function, improve mood, improve sleep. A lot of these folks have insomnia because when they lie down, their lungs fill up with water. And a frail person will not necessarily tell you they're short of breath. They'll just develop insomnia, or they'll develop nocturia, so they urinate more at night. So the symptoms are a bit trickier to detect. But by and large, treating the heart failure as per guidelines generally works in these folks, even though they are frail, especially in terms of improving their symptoms and quality of life. So despite that, in long-term care, residents who have a history of heart failure are less likely to receive recommended therapies, and the literature would suggest fairly obvious reasons for that. They're very complex people medically. There are multiple comorbidities. There are concerns about triggering adverse drug reactions. There are concerns related to the evidence around heart failure treatment. That's a knowledge transfer issue that we're trying to improve, but a lot of people doubt that the clinical trials on heart failure are applicable to seniors with heart failure in long-term care. And then there's this issue of diagnostic uncertainty, and in one autopsy series, 30% of people who died from heart failure, 30% of the deaths were misdiagnosed. So these folks were thought to have died from other reasons, but when they did the autopsy, they actually had fluid in their chest from their heart disease. So it's a sneaky diagnosis in many ways. It's hard to diagnose. So heart failure management programs exist in the community, and they were designed, interestingly enough, by cardiologists who look at the geriatric medicine literature and looked at day hospitals and said, you know, that would be a good idea for heart failure. And so cardiologists borrowed from geriatrics, which is interesting, and they developed these multidisciplinary programs that have nurses and physicians at the very least, and pharmacists and other allied health. And in the community, these programs prevent hospitalization, improve quality of life, and may even prevent mortality. In long-term care, there have been a few studies that looked at heart failure management programs for nursing homes, mainly in the US, the UK, Europe. And what these programs relied upon was, let's throw lots of resources at the problem. So in one study in the UK, they had heart failure cardiologists and nurses go into nursing homes and do the work in terms of optimizing the care of these patients. And lo and behold, they were able to do that. But as soon as they left, drug doses, drug utilization went right back down to baseline. Because none of these programs actually sat down with long-term care staff and figured out how could we help you do this yourselves more efficiently. So none of these programs address these issues with end-user input. All of these programs rely on resources that we just don't have in our healthcare system, and many of them sort of cherry-pick the patients that they wanted to deal with. So in the U.S., a lot of nursing home residents are actually community-dwelling seniors in convalescence, they're going to go home. So let's focus on these guys. So there's really a paucity of evidence in our sector as to how we do this best. So the objectives of our research program are to develop heart failure care process for long-term care for Ontario and ultimately Canada that reflect the heart failure guidelines of Canada, that are designed to optimally utilize the skill sets of all long-term care staff, that we can integrate efficiently into existing work routines, and that focus on achieving outcomes for the residents in terms of quality of life and minimizing the burden of symptoms. So we're going to present specifically on a study that we've completed that looked at identifying barriers to doing this in long-term care in Ontario, as well as some of the solutions that we might use to overcome these barriers. This is a complicated slide. So what this was essentially was a 3-year process of consultation. And I'm going to focus on phase 2 of the consultation, where we spent a lot of time with long-term care staff doing lots of focus group work. We did the focus group work by segregating the staff because we suspected there might be some interprofessional friction, so we interviewed personal support workers separate from the nurses who were separate from the doctors. And we had an expert panel review this to make sure that what was developed through these focus groups in terms of recommendations was consistent with scopes of practice, was consistent with the heart failure guidelines. So we did this work in 4 long-term care homes in Ontario, and overall 13 focus group interviews, 83 participants, a fair number of nurses and RPNs, 33 personal support workers, 14 physicians, and 7 nurse practitioners. So I will turn over the microphone to Veronique.
So doing the qualitative analysis, we found some overall overarching themes, which we could have grouped in 3 themes, 3 codes, I would say: communication gaps, knowledge gaps, and health system factors. And I'm sure that that is not all that surprising to you, because we see that with a lot of the best practice issues or the not so best practice issues in long-term care, that it's often related to communication, to knowledge, and to health system factors. We're going to go into a little bit more detail describing all 3 of these. And the first one, interprofessional within the long-term care home. There really is, it's very difficult to understand how interprofessional teams work in a long-term care home. We often hear that there is not a lot of interprofessional work. We also see that there is no good role description of how interprofessional work should be included in some of the different roles. And we do know that if teams are not working together, that the quality of care will suffer. So we have some quotes on that. I'm sorry. How did we go back? Thank you. So in the interprofessional communication, all groups, PSWs, NPs, physicians, and nurses recognize that it's important, but there's a lot of barriers. And so obviously the way the system works and the way the assignments and the shifts are laid out really limits the way how staff can talk to each other. And so what happens is that you have often RNs or RPNs that talk directly to a physician, but a PSW doesn't feel that they can directly access the physician. And what came loud and clear through all of these interviews is that the PSWs had a lot of observations and some knowledge about what was happening, but never felt that they could give that information on to the higher level. And so they also did not always have the language to do so. So they kind of saw that somebody was more tired, but then they might have not related that to heart failure. That information was not transferred to the RN, then the RN did not transfer that to the physician. And so that trust relationship between physicians and that frontline staff is a key component of improving best practice. Obviously, there is some institutional policies as well, where we really, it's a balance. What are the policies, what are the resident needs, and how can they be married together? And so in following regulations and quality of care, where is that point where you do what is best for the residents while respecting some of the regulatory needs? And what we see is that some decisions that, for example, nurses are making are driven by regulation, not by the residents' needs. And I know we've talked a lot about that at this conference, about this issue, but that cannot be the case anymore. Resident needs are the first ones, and the regulatory needs or demands cannot overtake that task-focused approach through the nursing staff. And then there's a lot of solutions that are trying to be put into place to promote interprofessional communication, and here are some examples of flow sheets and logs. There was even some nursing homes that use tapes still. Some of them are more effective than others, but we do see that that crucial shift communication is not always happening in a good manner, and a lot of information gets lost between different shifts. So some quotes here from a physician states that I trust the PSWs more than anybody, more than the nurses, more than myself, because they see them, the residents, all the time, and they are the ones doing the care. And so it's great if you see a physician directly in conversation with PSWs, but PSWs are not always ready for that as well. And so another physician here says that communication between the PSW and the nurse, that seems to be always where there seems a conflict. They never get along from what I see. And so this physician observed that PSWs observe a lot of subtle clinical changes that are really, really important in the diagnosis and treatment of heart failure, but somehow that information does not get reported to the nurse and therefore does not get documented. And then that physician misses that information to make an accurate diagnosis. And then the PSW states that the two RPNs do a verbal exchange of shift. So a lot of the times that information is not shared with any other staff. And there is the due diligence part of us looking at the information on our own and finding out what's going on. And guess what happens as a PSW when you start your shift? You do not have a time to look through the shift report or any of the cardexes or any of the care plans that have been changed. So if two RPNs or an RN and an RPN do some of that shift exchange, a lot of that information gets lost. That is very important for PSWs because that's how PSWs organize their work as well. I often see in practice that PSWs do their own verbal exchange between shifts. And so as an RN, it's very important for me to hear that information as well because they often say, oh, she's doing kind of a little bit better than yesterday, but it's not the same. Well, that's an important indicator there. What is happening? Is it fatigue? Do I need to go in and do some more assessments? So that interchange at shift change or during the shift is really an important carrying over of information. A second theme we see is the mistrust and lack of respect, unfortunately. And so this physician describes it as the main issue when I visit the nursing home once a week. And the nurse would be checking the residents between visits, and I do not think they can accurately assess many of the signs and symptoms listed above. And there's not a very flattering comment to be made about nurses. However, we see that in the four groups that there is a clear lack of clinical skills to do good assessments. And so that is a very scary trend. And we've talked about this already in other presentations, but what we see is that because there is such a task-focused approach, nurses, PSWs, MDs, and nurse practitioners have to make decisions, and they look at aspects of assessments and doing certain components of the assessments and record that information, but they skip over some other aspects of the assessments that are also important and that are ignored because of workload, because of time issues. And so there's a lot of symptoms and signs that do not get picked up until it's too late or until there is an acute exacerbation. And then a PSW talking specifically about interprofessional care says, I don't know. I think you just get shot down pretty fast because you don't have the education behind you like they do. And so this is a PSW that observes certain signs and symptoms, but that does not have the confidence or the language to convey that information to the RN or the RPN and to use it, as they say, in their language and say that this is really important. You need to have a look at this resident. And we see that often in practice. PSWs know when something is wrong, but they cannot really describe what is wrong, but they just know something is wrong. That is so important for any RN, PN, or nurse professional or physician, because if the PSW tells you something is off, something is really wrong. There's lots of research on that PSWs are able to pick up those signs and symptoms. And so even if that's not the right diagnosis or they do not have the regulatory scope of practice to set a diagnosis, this is a sign that needs to be followed up on. And then the PSW importance in all of this is that what this one physician describes as what's more important is the change, and the people that know it best are the people that are with the resident on a daily basis. And it's not the physician. And it's definitely not the RN. It's the basic health creator, the PSW, that knows the patient and knows when something is changing. And I've heard things as simple as, she's just more tired. She couldn't get herself up today. Or, she's off. Her clock is not ticking like it was yesterday. Those are symptoms of fatigue. Something is brewing there. It might be an infection. It might be heart failure. I don't know what it is. I have to do a proper assessment to find out. But this is important information. PSWs don't feel value in their role of picking up change. They are valued for the bed and body work, or so they describe it. And that's not my opinion. But they describe it that way, and so they feel that they cannot come with some of these signs and symptoms to the RN level or RPN level and describe them. And they definitely don't feel that they can come to a physician with that information. An additional component or an additional theme that we found is the rigid application of policies hindering good care for older adults in long-term care. And so this quote clearly illustrates that. One PSW recalls expressing concerns to a nurse about the ability of one particular resident with a history of heart failure to attend a meal. And the PSW was reminded that all meals are to be taken in the dining room. And the PSW actually returned the resident to the room because she just was not doing well, and the resident died later that day. And so this is a clear example, a very extreme example, but a clear example where a PSW knows that there was a change in the condition of the resident, and where an RN was not able to pick that up. And an RN would not be able to pick that up at that level because she has not been doing the morning care or anything like that. The second main theme was the big knowledge gaps that we found in all 4 groups, which is a bit scary. And so obviously they're related to clinical skills and diagnosis, to the procedural skills or actual prescribing the right medication, and to really look at what is the resident complexity and how are we going to diagnose the exacerbation of the heart failure. And then somehow in the interviews it became clear that staff considers heart failure as a normal condition. It is part of growing old, and they're going to solve that problem in acute care, and if they have not picked it up there, then we cannot do anything about that in long-term care. So the resident complexity is demonstrated by this quote. In general, patients are more complicated, even in a place like this, meaning long-term care, and they're on a myriad of medications which may change, and it's very complicated. And long-term care homes are very akin to hospitals, acute hospitals. So this physician struggles with that. They're more complicated, but what are we going to do? They have so many medications. Can I start changing some of those medications? What is the priority here? And is heart failure one of those priorities that I should be treating? Which is fascinating, especially when we've heard in the previous slides that that is actually something that you can do about this. And then an RN states that our biggest problem is to distinguish between all the different causes of symptoms. And so obviously there is a clear gap of knowledge here because there is symptoms and signs that are recognizable and that need to be recognized at certain levels of a disease. And so nurses do not always have the knowledge to recognize those. Clinical skills deficits was a very, very big issue in these in what we picked up on the focus groups. And I would say not only related to heart failure, I see a lot of other best practices that have clinical skills deficits. And the PSW states that a lot of times it seems there's dehydration. And the first thing you do when them is make sure they're drinking. Bowels are a big part of it. And so this whole concept around going to the bathroom and having bowel movements for PSWs was directly related to heart failure. And it was very hard to understand in the first couple of interviews where this came from, because one of the PSWs told me heart failure is when they are sitting in the bathroom and they're straining to have a bowel movement, that's when it can happen. So it's an acute cardiac event. That's what heart failure is. And so heart failure is not well understood. People do not know what it is, or some people do not know what it is. Physicians sometimes struggle with this concept as well. You got some hunched up person. How do you even hear chest all the time? And certainly to look for the AVD, if the neck muscle is standing out, it's very different, meaning I am not doing an assessment. And so we cannot skip over our assessments, because if we skip an assessment, we don't really know what's going on, and we cannot treat a person if we don't know what's going on. So this knowledge gap was very, very clear in the interviews. And then the RN states that we're kind of relying on information that comes to us. So if the PSW is not identifying factors, by the way, we're not listening to those factors, but if they can identify it to the RPN, or the RN can identify the issue, and if we're not told some information, we cannot deal with it. So there really is not even the mentioning of doing their assessments themselves. Like, if somebody does not tell me what the issue is, I am not going to deal with it. So there really is a miscommunication here and a lack of knowledge. And then I'm just going to hand it over to George to talk about procedural deficits.
All right, so we'll move along quickly. But essentially, this is from a physician. These are 2 quotes from physicians which illustrate they're different approaches to the same kind of patient. And I know there's probably a lot of non-cardiologists here. So essentially, in the first case, this fellow was treating the resident as per the way the guidelines tell you not to treat the residents. So essentially, give him a little bit of diuretic and she's going to be okay. Whereas the other one would say, well, let's get an investigation so we can figure out what medications to use. Let's weigh them on a regular basis. Let's make sure they're not taking too much salt. And the medications that this physician is considering are the evidence-based medications. And in his opinion, that works quite well. So some physicians seem to be not aware of what the heart failure guidelines would suggest be done, whereas others are. And that's this procedural skill deficit that we're talking about. The other final concept is obviously, and everyone knows here, that long-term care is an incredibly complicated setting in which the resources are often deemed to be insufficient. So nurses face a lot of non-clinical demands, and we'll give some illustrations of that. Heart failure patients accumulate fluids, and the best way to identify when someone is accumulating fluid is to see if there's a change in weight. But if you bring up that topic in long-term care, you get a lot of pushback. For obvious reasons, it's a lot of work. Documentation demands, we'll talk a little bit more about that. So nurses complain that we're always writing stuff down, we're documenting, we don't have time to do these assessments. And then there's the intensity of monitoring for other conditions. So there's other conditions in here. So if we do heart failure better, are we going to sacrifice time spent on other things, like diabetes or blood pressure? But again, a lot of the staff had some very interesting observations. So here's what one physician noticed on the weekend. They're always short-staffed, and here's the nurse spending 2 or 3 hours trying to find staff to come in and do the work. I mean, that's not the job of an RN. If the RN doesn't have time to see assessments because they're doing administrative work, is that reasonable? Here's the comment on weights. So we're adding daily or even weekly weights. I mean, in a heart failure clinic, we're talking daily, but even weekly weights, that's a huge time factor. The staff are not happy doing that, and it's a significant burden on them. But this RPN said something very interesting. She said, I feel we're taking their blood pressure all the time. And I think, what if they were at home? Would they be getting their blood pressure done every day at the same time, or would they only do this so when they go to the physician? Does it make it makes sense for us to be monitoring blood pressures and blood glucoses all the time on these folks when maybe they wouldn't be getting that intensive monitoring at home or in another setting? In other words, are there other things that we're doing that maybe we should do without that would buy us time to look after these other diseases? So again, when RN, our priority is paperwork, we've lost our focus. So finally, to wrap up, they did offer some potential solutions, and it was quite interesting in some of the solutions being offered by all staff. So they wanted greater interprofessional emphasis when physicians came to visit and do rounds at family conferences. The PSWs, the RPNs, the nurses, they wanted to be there with the doctor. And sometimes they wanted the doctor to be there with them when they were having family conferences. They were insistent that this would be a better way to deliver care. They were all on board that any in-house communication strategy be developed in a cooperative fashion with the staff. They were all cognizant. In one nursing home that with 3 floors, there were 7 bulletin boards stashed here and there where different aspects of shift change communication would be stashed away that only the RPNs might have access to, or the PSWs. And there was recognition that this is wrong, but if we're going to fix it, we need to do it as a group. And even one PSW said, you know what, why don't we have case conferences on a weekly basis for the most complex residents, where we would all sit there and discuss the resident as a group. So we're over time, aren't we? Okay, here was one very enlightened physician who basically come up to a PSW, and it was very touching what he said. He would go to the PSW and say, can you give me a hand here? And the PSW says, no, I'm just a PSW. But the physician said, that's what I want. You come with me. But what he was finding is when he was trying to involve them, they had this unfortunate experience of having been separated from care decisions for so long that they were reluctant to come in to help when they were asked to. So we'll just keep moving here. So in terms of addressing knowledge gaps, everyone agreed we need education. It's got to be tailored to our needs. And again, this is not stuff that we came up with. This is from the staff themselves. They wanted small group learning. They wanted multiple approaches to teaching. They wanted tools. They wanted sessions. They even said, let's have some bedside sessions. We have a doctor, we have a nurse practitioner who comes in and takes the RPNs to the bedside and shows them how to assess edema. And they wanted that. They wanted more of that. Case conferences, not just for looking after patients, but also as opportunities for education. And again, greater access to specialist physicians. I don't know many geriatricians who go into long-term care homes. It's potentially a missed opportunity for education. So again, we'll just try to get through this fairly quickly. But again, the third quote down here is very interesting. This was a nurse practitioner who basically said, "I'm tired of standing in front of a classroom to do didactic teaching. I do it at the bedside. I just grab the PSW and the nurse and we go to the bedside and we teach right then and there." The documentation bit was interesting because some people were complaining that the MDS takes too much time. And it does take an awful lot of time, and partly that's perhaps the way the ministry decided to have it implemented with some redundant note-taking. Yet others were actually starting to use the MDS RAPs to help them guide care, and they were seeing value in having that in terms of moving forward and doing things for the patients. So by and large, all long-term care staff essentially recognize that the importance of improving interprofessional communication, and everyone who stated that they would be willing to work at this, with the proviso that they could incorporate that into regular long-term care routines. You can't take people off the ward for any length of time. They identified the importance of multiple modal tailored education programs, including case conferences and having all staff attend case conferences, as well as bedside teaching. And the key role and the importance of enhancing the PSW capabilities was recognized by all. And just some final thoughts. I guess the main message here is that the overarching deficit is one of clinical skills. And the clinical skills development for long-term care staff from the PSW to the physician has really not kept up with the medical complexity of the residents. And we can talk about different tools and adding staff and investing money and all kinds of things, but until we deal with that, we're really not going to address one of the key problems in long-term care. The other thing is this is a zero-sum game. We have limited resources. The ministry may not invest that much more money. So the question is, if we enhance heart failure care, are we going to save time by having less sick patients that we need to deal with on an emergency basis? If not, is there anything else in long-term care that we could scale back? We all know now that very intensive glycemic control in frail seniors is not a good thing for their health. So maybe that's something we should look at. Do we back off in terms of 4 times a day blood sugar monitoring because it's not helpful? Blood pressure. Do we need to measure blood pressure in a person who's not dizzy? I don't know. And finally, the whole issue is to recognize the MDS as a clinical tool, and perhaps that might be another way to save time and make it more applicable to daily routines. So we'll end it there and pass it back to you.
Thank you very much. Very practical knowledge. I'm sure that we have quite a few registered staff in the room. And I do know that there was a PSW focus group going on at lunch. So I hope that some of those PSWs are in this room too to hear that presentation. Great. Next will be Dr. Alexandra Papaioannou. Better, I hope. And she is the professor in the Department of Medicine and the past director of the Division of Geriatric Medicine at McMaster University, with a joint appointment in the Division of Rheumatology. Dr. Papaioannou is the chair of the Scientific Advisory Council of Osteoporosis Canada and the past chair of the board, and has served on a number of Ontario Ministry of Health and Long-Term Care committees, including serving as the co-chair of the Ministry of Health and Long-Term Care Osteoporosis Society of Ontario. She is the lead investigator for the Long-Term Care Ontario Osteoporosis Strategy, an associate member of the Centre of Evaluation of Medicines, St. Joseph Healthcare, and a geriatrician at the Hamilton Health Sciences. Please join me in welcoming Dr. Papaioannou.
Thank you. So I think that George's presentation was a nice segue. And Veronique, you're wondering what the threads are with fracture and heart failure. So the threads are, there's a nice BC paper in British Columbia by Dr. Rowland demonstrating that fractures, pneumonia, hip fractures, pneumonia, and heart failure are the leading causes of transfer to acute care. And I'm a geriatrician and I work in acute care, and I see those individuals coming from long-term care, and it is a terrible way to be and emerge. We don't do a very good job with the long-term care residents. They tend to be low priority. They don't present the way we've been trained as physicians and nurses. So they don't present with heart failure. They don't say, I'm short of breath. They present being delirious or confused. Even with pelvic fractures, they present, or spine fractures, they present as being difficult. And so sometimes we see people being placed on antipsychotics instead of being treated for their pain for their vertebral fractures. So I'm going to speak to you about a study, the vitamin D and osteoporosis study. We've had a number of partners. This is Courtney Kennedy, one of our PhD candidates, PhD. The Ontario Osteoporosis Strategy, Medical Pharmacies Limited, the Ontario College of Physicians, as well as Osteoporosis Canada. We're going to talk about the vitamin D use in long-term care, calcium and bisphosphonates, and really to follow up on the first presentation, one of our multifaceted approaches to improving care in long-term care. Just so you're aware, the Ontario Osteoporosis Strategy has been underway for 5 years, and I was the external chair to the Ministry of Health. So I really stress the importance of targeting long-term care. And so you'll see the bottom objective of the strategy is improving the quality of life for those with osteoporosis and fractures. So the residents in long-term care, through a number of studies, focus groups, have talked about the prevention of pain. And a hip fracture is a very painful event. We created osteoporosis long-term care toolkits that went out to all the long-term care homes. They are available on the website www.osteoporosis-longtermcare.ca, and they can be downloaded. Carly Skidmore is standing by the osteoporosis strategy table, and there's DVDs and tools that you can take. So there's been a number of in-services, webinars that have gone out to the province, and the RNAO has partnered with us as well to disseminate. This is the DVD. It's available on YouTube, but it's also on the website, both in French and English. And it's about 10 minutes. It's geared for healthcare professionals in long-term care, but also could be used with your family members, the residents, and also for physicians. It's a really quick, nice snapshot. Here's our website. There's tons of resources on the website. There's PowerPoints if you want to download them for your staff. There's the DVDs that are easily accessible. What's interesting is we've had 10,000 visits. Mary Lou Vanderhorst, who works with both our teams, developed the website, 10,000 visits in the first year, many from international sectors. So how are we doing in Ontario since the strategy initiated? So originally, at baseline, less than 20% of long-term care residents were on vitamin D when we started the strategy. Why is that important? I've just reviewed the RNAO's best practice on falls reduction. And Gillespie and Cameron have just published they've reviewed all the studies on falls. And the most profound thing that you can do, that's the cheapest, is vitamin D reduces rates of falls. A lot of the other interventions we do reduce falls, but they haven't been well shown in randomized controlled trials. There's not the same quality of evidence. So in Ontario right now, and this is data from, I see Dennis in the audience, from Medical Pharmacies Limited, we've reviewed over 22,000 residents. The average age is 83, not a surprise to this audience, but it ranges between 73 and 93. And 70% are women. Those residents, this is all residents, not just those who have fractures, over 60% are now on vitamin D, and that's really that's tripled in 5 years, which is really quite remarkable because most interventions don't have that kind of improvement, maybe 5 to 10%. Calcium, about 33%, and that may be quite appropriate. We know that too much calcium can constipate people. People are on a lot of pills in long-term care. There's also been a signal that it may be linked to heart disease. So at most, what we're recommending is 1,200 milligrams of diet and supplement. Anybody that's taken, how many people have taken twice a day calcium? Have you taken it? It is really constipating and bloating, and you don't feel well, and it's often that, not the drug. And some of the dietitians in the home are adding calcium-rich puddings. Osteoporosis medications were about 20%. Why is that important? Because there's been nothing in long-term care that reduces fractures other than medications. So all the falls interventions we do, everything we do for the high-risk patient, the resident, this is what has prevented that transfer to acute care. And that's really the goal. So for the high-risk individuals, what we find is when the nursing staff has documented on admission that there's been a hip fracture osteoporosis, the team is more likely to treat. We've just gone through a guideline process to review, make recommendations for long-term care, and we're really focused on that high risk. So on admission, if you can ask the family, has the resident had a fracture? If somebody's really kyphotic or curved over and they're agitated in their wheelchair all of a sudden, think about have they had another spine fracture rather than the antipsychotic. Because when you break another bone in your spine, when you have dementia, you might just start yelling when you're in a wheelchair for half an hour. So we really noticed that if the nursing staff document, ask the family, we know we're terrible at transfer notes from acute care. People fill them out in 2 minutes. There's often not a lot of history or information when people come to long-term care. And that's challenging. So the long-term care study that we did, that's called the VITO study, it really looked at trying to bridge knowledge translation into long-term care. What's the best practice? There are so many articles now coming out, so much research. How can you apply it? How do you have time to look at the evidence? Here are our collaborators. So there was a number of focus groups in long-term care to really inform us about what the best way to implement this was. And we had a number of primary care physicians. There were 40 homes, so it was a randomized controlled trial. Half received the intervention, half did not. The ones that were in the control eventually received the intervention, but we found homes from across Ontario, and some you can see are in small communities, some in large communities, which is really different than your typical research, because typically research happens in big teaching centers where it's easy to recruit. And it is very challenging to recruit in long-term care. So what was the target audience? Interprofessional teams. So this was the fun part of this intervention that we really enjoyed. It was 3 interactive sessions, 6 months apart, and they occurred in the regularly scheduled PAC meeting. We initially went out to the homes, but that became challenging for travel and the specialist time. So we started with the webinar, and then we went to the phone and the PowerPoint on the other end. So what were the elements of this? There was the learning modules that were geared for long-term care. There was the quality improvement program, Plan, Do, Study, Act. There was the audit and feedback that MPGI was able to give the information on the individual's prescribing patterns. And there was what we call the point-of-care tools developed for long-term care, particularly the pharmacists and nursing staff and physicians in terms of appropriate prescribing. And these were the control arm all received the toolkit. But we know publications, posters, creates an awareness, but it doesn't always make a difference in what we do. So, did the VITOS intervention work? I can tell you we just saw a peek of the results, and yes, it did work. But it hasn't been published. Courtney's just finishing that off for her PhD. So what are challenges to implementing knowledge translation in long-term care? You know, one of the challenges is that we, in teaching hospitals and the specialists that all develop guidelines, whether it's diabetes, heart failure, for osteoporosis and fracture, they're not looking at the type of residents that live in long-term care. Who have multiple comorbidities, are on 10 medications, kidney problems. People think, it's interesting how many of my colleagues in even the community and family practice who don't do long-term care, the family practice residents who really aren't exposed as much to long-term care as you would like, feel that we can develop the same kind of process for acute care as you can for long-term care. And it's a very different, we heard the different combinations of health professionals is very different than acute care. So, do long-term caregivers embrace the VITOS model? And this is the qualitative results that were led by Dr. Lynn Lowfield. And so we interviewed directors of care, consultant pharmacists. We weren't able to interview as many physicians as we would have liked. We had 11 respondents. The mean age of the directors of nursing was 52 years of age, and they had worked on average in long-term care for 19 years, between 6 and 28. And the pharmacists, 54 years, and they had worked in that sector for 14 to 41. So what was interesting is that the opinion leader on site was everybody's preference. When we submitted the grant to CIHR, they said we would not fund this. They would not fund it because they did not feel that that was a realistic model to have specialists visiting 600 homes in Ontario. However, certainly from the physicians that participated that I spoke to, they did like the access to the specialist by phone to go over their cases. So you knew you had 3 sessions with a specialist that you could then share cases. Did this make sense? What would we do? So they really liked that access. The audit and feedback was really important to the directors of care. The consultant pharmacists ranked at 5, which it may be because they see this data more often, but the DONs really like their own data. They all liked the PowerPoints. We developed a process indicator checklist that Mary Lou developed, and the directors of care in nursing like that, whereas pharmacists are not as familiar with that, and it's less important to them. They ranked it less valuable at 7th. Interestingly, the internal nominated champion often was the nurse or the pharmacist was valued as important. The consultant pharmacists really like the small group learning, so they liked that they could sit down with the physician and the director of care. The nursing staff ranked that a little less. We developed these treatment alerts, which really identified best practices. That came down further, and the action planning was kind of the last one. So, in conclusion, VITOS, this method of these 4 elements where you have the opinion leader, you have really case-based learning in the interprofessional team, very practical tips, who to apply the guidelines to, was well liked. The audit and feedback is also very important. People learn, but that's not enough to change behavior. So I think that many of the elements that you identified in your focus groups were part of this intervention. We're not the first to look at this type of format. George presented a number of studies. What was different was that the specialist was very much available on those 3 teleconferences and available in between through the research coordinator. So typically, they may not be there at the presentation. The PAC meeting was very critical that the physician, nurse, pharmacist, that the 3 were together in a room. Often there were other allied health team members like the pharmacists as well. There may have been some PSWs as well. But it was really geared to that smaller group. Some of the physicians would share this information with the rest of their colleagues. So I'll stop here. Okay.
Wonderful. I'm now waiting to find out what the results are going to be and how they'll be used. But I think it's a wonderful study, especially from a very small long-term care facility where the average age is 94. Some really great information. So next we have two presenters, and they'll be presenting on the use of order sets to enhance long-term care. Lori Brown, a nurse practitioner from NP Stat, and Dr. Stuart Egier from Trillium Healthcare. Lori Brown is a nurse practitioner and program lead of NP Stat. Nurse practitioners supporting teams averting transfers in the Mississauga-Halton-Lynn, and I'm sure we're all familiar with that program. NP Stat provides acute episodic care to residents in all 27 long-term care homes in that region. Services also include transitional care support between hospital and home and system-wide integration and innovation to identify challenges and opportunities in long-term care. Lori is the project manager for the Trillium Health Centre Long-Term Care Order Sets project. She, too, saw an enormous potential for this project to enhance utilization of evidence-based care, workflows, technology, and long-term care. Dr. Egier is a family physician. He's been in group medical practice in West Toronto since 1976 and has always had a special interest in the care of seniors. He is on active medical staff at Trillium Health Partners, at Mississauga Hospital and the Queensway Health Centre sites, and is medical director of complex care at both Trillium and the McCall Centre for Complex Care. He is attending physician at 4 long-term care homes and is medical director at 3 of these facilities. He became involved in the Order Set project as it applies to long-term care and complex care because of an interest in improving care and establishing best practice. We welcome you.
Okay, thank you. So just to find how to get out of here, escape. I'm escaping. Okay.
So this, everybody, is going to be a test on doctor-nurse collaboration.
And
we'll see how this works.
Where are we? Sorry.
Middle at the top.
Middle at the top. Thank you. Thank you. No. Okay. So, like all of you today, Stuart and I are very passionate about long-term care. And when we were presented the wonderful opportunity to lead a project funded by Canada Health InfoA, that in partnership with Trillium Health Partners, that supported to develop, implement, and evaluate order sets, over 50 of them, in long-term care, we said absolutely yes. This partnership with Trillium, NP Stat, Canada Health InfoA also has 6 actual site partners. 4 of them are long-term care homes, and 2 are complex continuing care units at Trillium Health Centre. Patient order sets, they are a leading Canadian provider of evidence-based clinical decision support materials and technology, and they've been working collaboratively with us because of their expertise in this space. They have a network of over 250 hospitals and facilities across Canada currently using their order sets and technologies at the front line of patient care. The background for us doing this project was we know that currently there are over 77,000 long-term care residents in Ontario, and that's growing exponentially. We also know that there are greater pressures and backlogs in hospital, putting more of an emphasis on long-term care more than ever. Our residents are more complex. They have multiple comorbidities. There's increasing need for long-term care facilities to provide specialized services, including end-of-life care, dementia, better chronic disease management, and as well as increased requirements to meet staff core competencies, knowledge, and skills. The goal of the project then was we wanted to improve the quality and safety of care in long-term care and complex continuing care. The project seeks to contribute to the innovation of long-term care through order sets and technologies customized for the unique challenges faced by long-term care and complex continuing care facility. The project actually represents a significant step in building advanced technological evidence-based capacity in clinical workflows in long-term care. We want to support our clinicians as well as our staff as they are dealing with the ever more challenging clinical requirements of our residents. You know, this opportunity allows us to standardize practices, reduce time and costs, improve outcomes, and ultimately we know the heart of clinical process and doctors' orders have to be managed effectively, but how do we manage an army of physicians and clinicians and connect that to our workflow and organizational goals? Stuart.
Okay, so what are order sets? Order sets actually are evidence-based medical checklists. We are certainly compliant with all the requirements, even with the Ministry of Health. We have approached them, and they are aware of the project and are very supportive of what the changes are that we are putting in place. We have put together about 50 order sets altogether as they apply to long-term care and complex care. The goal ultimately is to improve outcomes for our patients and our residents. This was done actually and is unique to long-term care the way we have designed it. The original patient order sets were applicable to acute care. We have designed it specifically and changed many of them so they are more applicable to long-term care and complex care. You know, we use different medications in long-term care. The degree of monitoring changes from acute care to long-term care according to the staff. There is limited use coverage that has to be considered, and there's a whole difference in the frequency of lab testing where we don't have access to daily labs. So ultimately, order sets are the best way to manage changes in our residents' conditions. Many diagnoses, they come, of course, you know, with multiple conditions on arrival, but, you know, even during the course of their stay in long-term care, patients get into exacerbations of their COPD. They get into diabetes sick days. They get into problems with CHF developing, as we have talked about that. They have cellulitis of a limb. And so these are the kinds of things that are designed to be addressed with the order sets.
I don't know why this is not helping us here. There we go. There.
Okay. So there is a vast and growing body of knowledge in the medical field. We all know that. It is not possible for everyone to keep all of this to memory for every condition and circumstance. So this is a lovely photograph of Dr. Chris O'Connor. He gets the credit for, he's an intensive care physician at Trillium Health Center, and he gets the credit for about 12 years ago figuring out that this would be a very interesting application in the intensive care setting. It has been expected for so long that clinicians could have mental checklists that never failed and were always consistent, and that is applicable to the investigations that every resident requires and in therapeutics. Of course, you know, as you can see, doctors' legibility declines as time goes on and we're no longer in school, and this is really how we have developed the evidence-based checklists. So this is the picture of the typical bulletin board. It's not something we carry in our pocket. We do get all kinds of best practice guidelines, and these are good-sized documents that we also don't carry in our pockets on such topics as COPD and diabetes and hyperlipidemia. We can't read it all, and it's not really close by when we need it, when we're at the bedside or we're at the nursing station when we're actually writing the orders. So treatments are provided to patients and residents by doctors and nurse practitioners. Typically, this is, again, the handwritten treatment instructions. This is prone to errors, omissions, interpretation by staff who are reading it. There are a whole list of banned abbreviations, as we all know, OD, DC, OU, that we have tended to get very accustomed to over time, but are open to misinterpretation. And there are a lot of sound-alike and look-alike drugs. So, we've really wanted to try and get away from this. Anybody able to read that? So order sets then are evidence-based interventions. They are easy to read, except that that's a little small, but we're going to be doing a demonstration as well. When the order sets that are applicable to that particular resident are checked, it stands out in bold letters. The order sets that are not checked, that are left blank, fade out to the background a little bit. And there are also default orders, which are the obvious things that apply to every resident. So, notify MD or NP if oxygen saturation drops. So that's one of those automatic things that already has a check mark on the order set. Order sets lead to all kinds of improvements in care. When you're treating the congestive heart failure or the pneumonia, it's not always front of mind that you've got to consider DVT prophylaxis, but it has been demonstrated that DVT prophylaxis rates were improved by order sets by about 50%. By eliminating the handwritten notations that we always do when as a resident comes into long-term care and we have to list the 8 or 10 or 12 diagnostic tests that we want and include in that Tylenol, Gravol, bowel protocol. It gets to be a page and a half of orders.
So a little more about the project. And so increasing both the quality and the capacity of long-term care infrastructure has been critical in defining our project objectives. And the full rollout of the project's final stages actually hinges on an innovative approach to care delivery. So part of project discovery, we developed a steering committee, an order set committee. We targeted the 50-plus order sets that we wanted to do. We chose our pilot sites. We analyzed the workflow. We analyzed the technical requirements. We actually went to compliance, made sure and confirmed it was all met regulations, and started developing evaluation criteria through the process. We've developed our order sets. We've rolled out to our 6 sites. Through that, we've done a lot of system implementation, integration, training, change management, and we'll continue on to a benefits evaluation. The over 50 order sets, we have a handout here today that I think most of you have currently. There's over 50 of those order sets there. What are missing are some other key sets that we've already developed: dementia, depression, Parkinson's, sets. And beyond the order sets themselves, a number of these have associated documents, and the associated documents gives the clinician the clinical guidance and with the latest evidence that support that order set. The order set development process, the content development itself, utilized the interdisciplinary expertise of the clinicians, physicians, nurse practitioners, directors of care. We utilized even PSWs in looking at the content. Stuart Egger is the medical director for all of our 6 sites, myself representing a team of nurse practitioners, as well as numerous linkages with content experts in the field. The deployment of the order sets, this project represents a significant step to building advanced technological and evidence-based capacity into clinical workflows of long-term care. We're supporting the clinicians as they deal with ever more challenging residents in long-term care. Electronic access and completion of the order sets electronically are made possible with Entry Point, which is Patient Order Sets online tool and platform for computerized physician order entry. Entry Point is a web-based solution, it's cloud-based, that allows clinicians to access any of our order sets using an internet-enabled device. So your computer, your handheld, like your iPad. It integrates with the current IT infrastructure at your long-term care home, for instance, and it is able to pull in the resident and the demographic data from point-click care or any other EMR. It has a sophisticated analytics module, so at any point in time, you can get an instant analysis of at the point of care. For instance, clinicians and administrators can use entry points analytics to drill down to reveal specific data on the aspect of each facility's actual order set or any content in an order set. You want to know as a physician, what are the ordering practices of your colleagues at that home? That information is available. You want to see the individual residents' order sets over time and what's being ordered. That's all available through our data. So we're actually going to do a demo of Entry Point to show you how easy it is to do cloud-based entry of an order set.
So just as an aside, as an addition to what Laurie has said too, how do we get everybody interested in this? Well, it's been a challenge. We have, in fact, had one-on-one training with all nurses and all physicians at each of the facilities. We have also had a couple of dinners at some nice restaurants. That's always a draw for physicians sometimes to get out. And we have had some staff and physicians who are really gung-ho, who are really very keen to get started, and some who are saying, this is a little bit more time than I would like to spend right now. I'm not really ready to get started with this. So, we've had some challenges along the way. So just want to, as we're pulling up an example here, talk about a particular example right now. So we have, let's say, Mrs. O, who's a long-term care resident. She's 86 years old. Last night she was unsteady. She was irritable. Her temperature was recorded at 37.7. It was noted by staff that her urine was cloudy, that there was an odor. Her blood pressure, which is usually running around 130 over 80, is today 110 over 60. And her urine dipstick on point-of-care testing showed positive nitrites and leukocytes. So I think we all agree that we're now going to pull up a order set for urinary tract infection. We have it both for long-term care and for complex care because the medications actually and the level of monitoring is a little bit different at those two levels.
As you can see, there's a standard format for all order sets. We're not just looking at the medications. We're looking at the whole resident. So with UTI, right away we're thinking about, do we need to do any consults externally or internally? What are the vital signs and diet needs regarding this particular infection? What labs do we want to order? For any of our order sets that have antibiotics, we've included there the connection to residents who are on Coumadin, who need to have their Coumadin adjusted, need more frequent INR testing. It goes on to, I'm trying to get us over to the other side. Sorry, Phil. I'm having trouble with this. There we go. And so, are there hydration needs? We can check, we can uncheck to select our orders. If that order doesn't fit, we can actually free text him. If I want to order amoxicillin, I'm given kind of the standard dosing for the elderly at this age and stage, but I could also go into the other category. And if I don't find that there's something in that field that is relevant to this resident at the point of care, you'll see that there's kidney symbols. That's to let the clinician know that we must be reminded and look at their renal function because this drug will affect the renal function. We also have cues about inserting LU codes as well. And so you go through the order set here. And it's very actually quick and easy. So it's all standardly set up. So each order set looks the same and basically how you saw it, you check and uncheck. And then at the end of every order set, you have the opportunity to add additional orders. And so they have UTI, but they may also have something else related to the UTI where we can add additional orders to that. The other piece, so that's basically, we just did an order set. It's through Entry Point. It's cloud-based, where you would push submit at the end of the order set, and that goes directly to pharmacy. It will pre-populate the prescriber, so if it's Dr. Egier or myself, it has the checks available for the staff to come along and do their checks and signs. We submit to pharmacy directly through the cloud.
Now, there is at each computer station an electronic keypad so that we would be actually doing a freehand signature at that time and then submit, and the order set will go directly to pharmacy and to the EMR.
This project also includes a robust benefits analysis by St. Michael's Hospital Lai-Kai-Shing Institute. We've done our pre-implementation interviews. That'll be followed by post-implementation interviews. Essentially, to date, we've developed our 50 order sets. We've implemented in our 6 sites as of December of this year. For the next year, the sites will be using the order sets. We'll be evaluating them through that process. We'll be looking at the data, the analytics that are available through Entry Point to assess the orders and the ordering practices both during the implementation and pre-implementation to see if there's any changes in ordering practices. We're also looking at those top type diagnoses, heart failure, UTI, COPD, pneumonia, wounds, and to kind of drill down on those to see if we're making a difference with order sets. The project will wrap up in January 2014, and at that time we'll have a full report available. We often get questions, how can I get access to the order sets? Trillium Health Partners will certainly be posting the order sets, and we'll certainly talk about how you can access that and deliver that to your long-term care facility. So why are they important?
So the hope is now that the project that has been designed is going to help clinicians to achieve significant benefits, including clinical efficiencies, better access to the best available evidence, fewer adverse outcomes, fewer transfers out to hospital, enhanced collaboration and communication. We actually use a number of consultants in the development of the order set. So where Lori and I and the pharmacist and the representative from order sets would be on teleconference about twice a week when we first started to do this, there are a number of infectious disease specialists, geriatricians, respirologists, a variety of different consultants who are actually very involved in the development and especially on the associated documents, because there's actually a lot of drug doses, starting, maximum, adverse warnings, those kinds of things. This actually maximizes staff knowledge and skills and increases core competencies of your staff as well. And I am now, when I'm sitting doing a full admission order set or a COPD exacerbation, sitting down with my nurse and RPN on my floor, and we're going through it together. So we're actually learning this together, and the staff have been really appreciative in terms of the exposure to how to put this all together and in terms of the content. So in essence, this is a reminder system for all of us to deal with all aspects of the resident care, because these people are very complex and we can't always be thinking of every aspect of what the application is with each condition.
So there's a whole host of other ways that order sets are important, but I think the theme today is about interprofessional collaboration and communication, and we heard that in the presentations, and it's something we really emphasize as being really important for order sets. It's not just about a tool for the physicians or the nurse practitioners. It's about the staff, the learning. I've had many, staff come up to me and say, now I understand what happens after you come out of that room and you start writing orders. They can see our thinking process because we're going through a standard format of care. And because of the tools that are also bolster the associated documents, the staff say that they're also learning as well as we are by using best evidence and practice. Future opportunities. We would like to see and hope to see, the aim is to promote the widespread use of order sets in all long-term care homes. Just to highlight, though, even though you have access to now over 50 order sets, what will be probably the end of the year on a couple of websites, order sets have to have a process assigned to them. They have to be customized to your particular settings. They have to be implemented. There's a training and education component. The go live is very easy. It doesn't mean you stop other things. All your other work happens alongside it. For anybody who's interested in implementing order sets in their organization, you can certainly talk to us or contact Patient Order Sets. But once the foundation has been laid, what we would like to see is a discharge to hospital order set transfer to hospital order set. We see that there are inherent difficulties for all of us to manage our residents on long-term care. When they come back from hospital, we don't know what happened in the hospital. We get a hospital MAR, which is not true medication reconciliation. We propose a discharge summary that would have a discharge order set that would have a discharge summary. It would have the med rec. It would have the key records from that hospital stay, and it would travel electronically at the point of discharge before the resident arrives back into the long-term care home. We feel that will definitely minimize unnecessary transfers and readmissions back to hospital and allow us as clinicians and staff in long-term care to provide that excellent care that we do. All of these things dovetail nicely into Interact. We heard the Interact program. I won't say tools because we've all heard from Dr. Oslander this morning. But it dovetails very nicely. So that's the conclusion of our presentation. And anybody who has any questions, we're always happy to talk to you at any time. So thank you very much.
That was wonderful. It seems like a tremendous amount of work has been done. I think very important work, especially as we see our resident population changing and becoming more complex. So thank you very much. We do have a couple of minutes for questions or comments. If you would like to address any of our speakers today, please go up to the microphone, introduce yourself, and you can let us know who you're addressing your question or comment to. Okay, I have a quick question, probably for all of you. It's wonderful to see all of this work happening in long-term care, and as our population is changing in long-term care, so is our population in the retirement home and the supportive housing sectors. And nurse practitioner programs, unfortunately, we don't have access to that in those different types of continuum of care. And I'm just wondering if maybe in the future someone might put their mind to it, that I think it might be very beneficial, especially when we're looking at, the amount of hospital transfers that might happen from those types of care settings.
I'll start. It's interesting that you bring up that point because we had a recently funded meeting for guidelines funded by the Canadian government for fracture prevention and long-term care, and the long-term care sector said clearly to us, don't make them about long-term care, make them about frail older adults, because similar residents look the same now in retirement homes and at home.
Yes.
And so, even though the walls are kind of changing quite rapidly, I think the challenge is that the retirement home sector is a different sector with its own unique
It will have its own unique challenges, and especially...
Quite honestly, I have worked retirement home and long-term care and acute care, and at the moment I will not go to retirement homes for the problem that there is very little regulation, there is very little control over what's going on. The residents are out to walk-in clinics getting prescriptions and self-medicating, and I think it's too unregulated, and I'm very frustrated by it, and I think that has to be one of the next steps that the ministry and this group needs to push for, is proper regulation and proper control over the care and the health of the people in our retirement home settings, because it really is seriously lacking right now.
And I think philosophically, what we need to look at is a system that takes frailty seriously, and part of it is geriatricians haven't done a good job of defining frailty in a useful operational way, and we're struggling with that. But if I were to go home today and have a TIA or a little mini stroke, I would automatically get referred to a stroke prevention clinic. If I show up and emerge with chest pain and my troponins up, I go to the cath lab. If I fall and EMS comes to my house, half the time they leave me there. If I'm frail and I step into the emergency department, no one's going to ask about it. And I think we need to sort of decide that we need to start dealing with this in the same way that we deal with other chronic illnesses. I mean, a fall is the TIA of geriatrics. You know, a delirium is a TIA of geriatrics. We need to start saying, let's start looking at every senior who comes in through the emergency, and we have tools now to assess the degree of risk. And it's time to start thinking in a proactive way. I think we need to do a lot of work in long-term care to help out, but the point is you end up in long-term care from the community, and that's where we need to start thinking about what we need to do.
If I could just add a piece, I think the presentation by George and Alexandra are really important because I think we have to get by the concept of continually doing these didactic educational sessions in long-term care. That is not the answer. The crux to this is really looking at interprofessional collaboration and really honing in on that area and get away from the lunch and learns and get away from, we have somebody coming to talk at 2 o'clock. We have to do this at the bedside, and we have to do it as part of a team and a process.
Super. Thank you. Thank you very much. Any other comments that may have come to mind or questions? Okay, well, I'd like to thank all of our presenters. I'd also like to thank Surge Learning that sponsored this session, and Emmanuel. Is Emmanuel here? No? Well, thank you to Surge Learning also. It's been very interesting. I know that I've learned a lot, and you reminded me about a lot of things that I actually forgot that I probably learned 18 years ago when I started my career doing what I'm doing. So that was absolutely wonderful. I'd like to remind everybody that next will be the closing plenary session upstairs in the concert hall. So please, if you'll head up there. And I believe that all the presenters will stay for a little while if you have any other questions, especially with respect to the order sets. That would be super. Thank you. Thank you.